Thank you, Chairman. Good morning, ladies and gentlemen. The topic I received the imaging essential during mitral and T-valve intervention. Unfortunately, we don't have any available T-valve intervention device currently, so I have no experience in T-valve intervention. Today, I talk about mitral valve intervention alone, especially for TEER procedure. As of today, in South Korea, we have only one available mitral TEER device, mitral clip like this. Narrow 4mm clip and wider 6mm clip. And the usual length is 9mm and longer clip 12mm. These 2x2 combination, there were 4 kinds of mitral clip. We have to make a combination of these clips for TEER procedure. Most of all, during the TEER intervention, the appropriate septal puncture is the most important thing. We usually try the superior and posterior puncture to facilitate the delivery of the TEER devices. We are usually using a bicameral view in a transverse vascular like this, superior and posterior aspect of the interarterial septum. Usual septal puncture height would between 4.0 and 4.5 like this. But a slight modification of septal puncture height is needed according to the region characteristic. For medial commissural region, a slightly higher puncture height, 4.5 centimeter, is required. In contrast, for delivery of catheter to the lateral commissural region, slightly lower puncture height is required for 4.0 centimeter. But most of all, in our clinical practice, rather than bicameral view by plane imaging, we use the 3D guidance of the septal puncture as most important in our real clinical practice. At the time of tenting with a septal puncture needle, you can collect the tenting site of this patient. After guide wire insertion and after delivery catheter insertion, the optimal septal puncture height is slightly posterior from the medial commission. But when a slight deviation from the optimal septal puncture size make a big difference when it delivered to the lateral commissural region, that could be very problematic sometimes. But modification of the 3D full volume image with a slight rotation make like this image with showing fossa ovalis. At the time of fossa ovalis tenting, you can decide the optimal puncture site. After guide wire insertion and tenting and delivery catheter insertion, sometimes the direct measurement in 3D full volume with helpful rather than direct measurement in 2D or biplane imaging. The problem is in patients with hugely dilated left atrium, especially atrial functional MR. Usual posterior puncture produces the puncture height of 5 or 6 centimeter, greater than 5 or 6 centimeter. To obtain optimal septal puncture height less than 5.0 centimeter, the anterior puncture cannot be avoided. After anterior puncture, delivery of a TEER device is make a big problem. This is a live case this year in TCT-AP meeting in our center. He underwent major operation 20 years ago. The problem was the interarterial septal anatomy was not usual. We have a big difference in septal puncture during 1 hour. But the problem, the septal puncture was succeed. The problem is the live session started. We found that after live session began, the septal puncture height was too posterior like this. But we tried. The coarctation gap is not so big in this patient with functional MR. The grasping seems to be easier than we expected. That the problem was at the alignment of clip delivery system because of two posterior puncture. Because we have any difficulty to grasping anterior leaflet. One of the panelists recommended independent grasping use. After then, we make a grasping of this patient with like this with successful manner. So the two posterior punctures caused some problem in this patient. During the procedure, we have to identify the location of the septal after septal puncture, guide location is very important, especially in patients with hugely dilated left atrium. The fluoroscopy is not sufficient to identification of the guide wire incision. The left upper pulmonary vein, right upper pulmonary vein is the optimal guide wire insertion site like this. Most of all, after septal puncture, second most important thing is to obtain true bicommissure view. True bicommissure view indicates the plane exactly across the two commissure lines like this. After we have obtained the true bicommissure view like this, we apply the biplane imaging. Usually biplane imaging produces the 90 degree of perpendicular plane, the LVT view. This is the very second most important thing in DTF procedure. In a central region, usually biplane angle produces a 90 degree perpendicular plane like this. In this true bicommissure view, the orthogonal biplane image shows the good, excellent image of LVT view like this. The 3D APCIS view from very similar with the surgeon's view when left atrium is open. Guidance of clip rotation is very important. The exact orientation of the clip should be like this. Usually the coaptation line in mitral valve seems to be like this. The clip should be located exactly perpendicular to the coaptation line. So in central region, the biplane angle should be 90 degree orthogonal plane. But commissural region, especially lateral medial commissural region, the biplane angle should be adjusted to the acute angle 60 degree or 17 degree like this. So in 3D APCIS view, we have to recast the intervention cardios. The clip orientation should rotate clockwise almost 90 degree. The clip rotation should be like this, perpendicular to the commissural line. The problem is, as I mentioned before, for commissural lesion, especially in this patient, have lateral commissural MR like this. In 90 degree, produces the suboptimal image of the LVT image. After we adjust the biplane angle in acute angle from 90 degree, 65 degree, the image can be optimized after adjust the biplane angle like the 65 degree. The grasping plane is optimal for this patient. Sometimes biplane imaging adjustment is not sufficient. In this patient, we have to use a deep gastric view as single plane image produce the two grasping to grasp the leaflet insertion to identify grasp leaflet insertion is very important in this single plane with a deep gastric view like this. Sometimes 3D MPR image is very helpful, but like this 3D image show from the 3D APCIS view from left atrium. This image from the ventricular blue from the apex. 3D MPR image, bicommissural LVOT and short axis are very helpful for the TF procedure. Let me show one case example. Delayed cardiomyopathy is a severe functional MR. You can clearly see some coaptation gap in this area. We have planned two clip strategy like this, one wide clip or two wide clip or one wide or non-narrow clip, like this. The problem is during the TF procedure, can you record the huge coaptation gap? What can you do next? Maybe Dr. Amaki will talk about the detailed procedure to reduce the procedure gap. We applied the high PEEP and the high dosage of IV furosemide to reduce the venous return like this. As you can see, the coaptation gap are much reduced from the original image of the 3D APCIS view. We grasp one axis double clip like this. After that, we are applying the second clip just next to the first clip. We deployed two mitral clips here. After 1 month follow-up echo, you can clearly see just to create one MR between the clip and the mean pressure onto just a 6 mmHg, the successful result of the TF procedure in this patient. But this is just 1 month ago, we had very difficulties to grasp this patient. As you can see, the problem was the P2 coda rupture with 86-year-old female, but the problem was the image was very poor. The problem was we cannot clear the posterior leaflet, especially posterior annulus, but as time goes by with accumulation of the tear experience, we did intuitive procedure in this patient with just the central lesion easier than commissural lesion. The image was very poor. We are applying first SCW clip like this, but some MRJ to just next to the first clip. We decide to put the second clip just next to the first clip. The alignment seemed to be very good. The image was very poor. I think that the result was very successful. After just 1 day after TEER procedure, immediate after a TEER procedure shows just a trivial MR in this patient. But let me show some guidelines from the American Society of Echo, the guideline of standard evaluation valvular regurgitation after percutaneous valve repair replacement. The findings of mild, equal to mild or less than mild degree MR after TEER, something like that. We have to evaluate these parameters like this. Vena contractor width at the PGR radius less than 3 millimeter, and usually the pulmonary vein improvement is most important thing I will talk about later. The LVOT, the cardiac fibrillation also important. The development of the SAC, spontaneous echo contrast in left atrium is most important thing to indicating the success TEER procedure. Let me show one case example. This patient also has P3 coda rupture, the P3 location almost commissure. The problem is we have to evaluate the pulmonary vein reversal in this patient. The problem is only reversal flow show in left upper pulmonary vein, no reversal in right lower and right upper pulmonary vein. In patient with eccentric MI, especially commissural region, we have to evaluate 4 components of pulmonary vein like this. Just only one pulmonary vein, the reversal can be seen like this. But after we apply the first SCW clip like this, some MRJ are both sides of the clip. The left upper pulmonary vein reversal normalized like this. We have to put the second clip. After second clip, just next to the first one, as you can see, the right upper pulmonary vein reversal, after second clip implantation, the S-wave velocity increase like a normal pattern of a pulmonary vein. It's very important for TEER procedure. After immediate post-echo shows just a grade 1 MR between the clip like this. Sure, let me show another case example. This is a age 3-year-old female with P3 coda rupture, almost commissural prolapse like this. We have to decide 2 clip strategy with the first clip implantation like this. You can see some MRJ are just next to the clip, just mild or mild to moderate. After 1 clip implantation, transmitral beam pressure onto just 1 millimeter mercury, left upper pulmonary reversal was normalized like this. The most of all, the evaluation of pulmonary vein flow is most important during the TEER procedure. The improvement in pulmonary waveform, disappearance of the reversal flow, or change in SV velocity, increase in S velocity, the increase in SV velocity ratio is most important during the TEER procedure. According to some literature, especially pulmonary vein assessment is an independent predictor for cardiovascular outcome or something like that. A change in S velocity, change in SD velocity is most important during the procedure. This is another analysis. The pulmonary vein assessment, especially in S velocity change, SD ratio increase, the improvement in pulmonary vein waveform were also independent predictor of composite outcome. Yeah, in summary, let me summarize my talk of today. During the TEER procedure, but septal puncture with 3D guidance is very important. Essential image is a pipeline with 2D, but nowadays we are using 3D guidance at the time of tenting of puncture needle. Slide posterior from the medial commissure is the most appropriate septal puncture site for MTO procedure. To obtain true bicommissural view is very important. After applying the biplane imaging with a transvagal echo, produce the exact LVOT view. The problem is in central region, bicommissural view should be orthogonal, 90 degrees. But medial region or lateral region, biplane angle should be adjusted the acute angle 60 or 70 degree I mentioned before. The creep orientation with 3D image, especially 3D APCIS view, another important thing during the TEER procedure, the clip orientation should be perpendicular to the coaptation plane. So how to there is manual to reduce the coaptation. I think Dr. Amaki will talk about in detail later lecture. The peer procedure in patient with poor image, but as it depends on the center experience in patient with poor image, we can try TEER procedure with caution, and I mentioned as before. Finally, I emphasize the importance of pulmonary vein evaluation, but especially in patients with eccentric MR, degenerative MR, for pulmonary vein evaluation very important because just one pulmonary vein reversal can be seen in this patient group. So disapparent reversal flow or increase in S velocity are all very important for the TEER procedure. Thank you for your attention.